thanks to the work of Dr. Danielle Dargent, the radical trachelectomy is now considered the standard of care treatment for young women with early stage cervical cancer with lesions measuring less than 2 centimeters. However, as I said, the procedure has been mostly validated for lesions under 2 centimeters. Now, for young women who wish to preserve fertility but have lesions greater than 2 centimeters, there's currently no standard treatment approach to offer. Obviously, women can choose to have radical hysterectomy, but that would take away the fertility potential. So the other two options we have is either to undergo upfront abdominal trachelectomy or robotic trachelectomy, or to undergo neoadjuvant chemotherapy followed by fertility-preserving surgery. So let's look at those two options. With regards to the abdominal trachelectomy or robotic trachelectomy in well-skilled surgeons, the procedure can be performed successfully. One can obtain negative margins. However, it is not an easy procedure to do, and there's a substantial number of patients who will require completion radical hysterectomy. If one gets negative margins, the problem is a substantial proportion of those patients will have on final pathology positive nodes or other intermediate risk factors such that these patients will be recommended to receive adjuvant radiation or radiation therapy. And obviously the problem is it takes away the fertility potential, and it also takes away the ovarian function unless the ovaries have been mobilized otherwise. So these will have long-lasting side effects and morbidity for those young cancer survivors. The other option is to use neoadjuvant chemotherapy followed by fertility-preserving surgery. The concept there is to shrink the tumor with the chemotherapy to then allow fertility preservation. There has been several studies, 5 or 6 recently published, using neoadjuvant chemo, and the result or outcome of the chemotherapy is actually quite interesting with over 70% response rate. The obstetrical results are also very interesting with the majority or 40% delivering at term. There have been very few recurrences, and it's important to point out that most of these recurrences have occurred in suboptimal chemo responders. Those who don't respond well to chemo are bad players. These patients have to receive either a full hysterectomy or adjuvant radiation therapy because they have poorer outcome. However, for those who respond well, the obstetrical results and oncologic results are quite encouraging. What remains to be determined or further studies are the agents, the optimal chemotherapy regimen. Currently, what has been mostly used is a triple chemo regimen, Taxol, ifosfamide, platinum. Researchers don't like to use triple therapy in young women because it has more side effects, and would like to get rid of the ifosfamide because of its gonadotoxicity. However, it is probably the most effective regimen. So researchers have now gone to Taxol and cisplatin instead, and as you all know, we're moving almost always to Taxol and carbo, which has been used and reported as well, and other investigators are using dose-dense Taxol carbo like in ovarian cancer. So at this point, we don't have a standard regimen for chemotherapy. We are greatly in need of a clinical trial or a study to further evaluate these elements. But in the meantime, preserving fertility in women with lesions measuring more than 2 centimeters is certainly a great challenge. It needs multimodality, and it needs also a multidisciplinary approach.